Hello and welcome to Medical Opinion Asia and to Straight Talk, our continued series of interviews with very senior medical specialists answering questions about those topics of medicine which are currently being discussed out in the communities and where a lot of people have questions that they would like to have answered. Today we're most grateful to have with us Dato Dr. Ghandhiraj Somasundram, who is a senior cardiothoracic surgeon. And he's going to specifically touch on questions related to the current surgical treatment strategies for coronary artery disease. So first of all, Dato, a very warm welcome and thank you for giving us your time to answer these questions. It's not unusual for the members of the public to think they know what's going on, where actually they don't, but they're a little bit afraid to ask questions. So what we've tried to do through these programs is to give an opportunity to have doctors like yourselves to actually answer these questions. So again, we thank you for being a part of our program. Maybe I can go straight into one of the first questions that have been sent to us by our viewers. And the first question is actually, how do you treat patients with coronary artery disease?
Well, over the years, patients with lesser complex coronary artery disease, obstructive disease, have been treated with PCIs, otherwise is known as percutaneous coronary interventions. And the more complex obstructed coronary artery disease have been treated with coronary artery bypass surgery, otherwise known as CABG. Now, with the advent of newer stents, drug-eluting stents, bioabsorbable stents, and improvements in the armamentarium of angioplasty techniques or PCI techniques with better catheters, better balloons, perfusion catheters with rotablators to attack very tight, aggressive lesions, with imaging modalities like intravascular ultrasounds, fractional free flow reserves. All these have actually allowed cardiologists to intervene in more and more complex coronary artery disease. So there was an absolute diversity in the way cardiologists and surgeons were practicing in many of the institutions all over the world. There did not seem to be any measure of control and regulation in the way cardiologists and surgeons can actually treat their patients in a more effective manner.
So it seems that this is quite a difficult area for people to grasp a hold of and to understand.
Yes, indeed.
And I think one of the things that's quite clear is that if they hear this from one doctor, maybe they would be better to be hearing a little bit more information, to be absolutely clear in their own minds what's going to be done. Yes. So I think this is, again, why we want to have such interviews, so yes, that you can help the public understand about this. Another question that's been asked is, so what is the latest or current way to treat coronary artery disease, otherwise CAD?
Right. See, what happened was in recent times, the cardiologists and the surgeons got together as a heart team concept. And there was a landmark trial that was conducted and published in 2009. The aim of the study, which is otherwise known as the Syntax trial, the aim of the study was actually to look at treatment strategies for patients with complex coronary artery disease undergoing PCI, that is percutaneous coronary intervention, or coronary artery bypass surgery. Now, the first year trials were actually published in 2009, and there seemed to be an edge benefit for patients undergoing PCI as against coronary artery bypass surgery. But when the trial group, the investigators looked at a 5-year period, there was a very clear indication, a definite benefit survival outcome for patients with complex coronary artery disease, particularly left main coronary artery disease, as well as this triple vessel coronary artery disease, who actually undergo a CABG, that's coronary artery bypass surgery. And with the syntax trials, to further look at what category or what group of patients will be referred or be sent for PCI or for coronary artery bypass surgery, there was this special unique scoring system that was developed, and that was known as the syntax score. Now, the syntax scoring system is a unique tool which actually looks at the number of obstructions in the coronary circulation and the complexity of the coronary circulation, and then you arrive at a score. And with the score, one is able to recommend for PCI or for a coronary artery bypass surgery to the benefit of the patient and the interest of the patient.
And this obviously, again, when you start to talk about scores, is this something that you explain to the patients and say, this is your score and therefore this is what I would recommend for your particular problem or your particular blockage that you may have?
I think in times to come, and you know, as surgeons and cardiologists learn that what you want to do or offer to your patients, you know, for good outcomes, the score probably is currently being practiced in many of the European countries, in the United States, and in Australia, where they use the scores as the guidelines to offer the appropriate definitive treatment for patients. And I think it will benefit doctors, because when you use the score, when you have guidelines and you direct your patients for the appropriate treatment, you are also safeguarding yourself from potential medical legal litigations. Because if you do a PCI on a patient who is a candidate for a coronary artery bypass surgery or on the reverse, vice versa, and something were to happen to the patient, you know, you could be facing yourself, you know, with the lawyers and being in court to avoid, you know, potential medical legal problems. I think it is best to follow certain guidelines.
The next question that has been asked is, are there any recommendations now for appropriate treatment of CAD?
Right. Since 2014, the European Society of Cardiology and the European Association of Cardiothoracic Surgery, along with the American College of Cardiology, have come out with guidelines for myocardial revascularization. It means guidelines for PCI as well as CABG. Now, they categorized or classified coronary artery disease as LAD disease, that is left anterior descending artery disease, proximal LAD disease, two-vessel or three-vessel coronary artery disease, and left mainstem disease. Now, when they looked at left mainstem disease, and they looked at the syntax scores, if you have a syntax score of more than 32, there was a class 1 indication for a CABG and a class 3 indication for a PCI, which means you should not be doing PCI because it will be harmful to the patients. So these patients with a syntax score of more than 32 were recommended to have a CABG. And when they looked at patients with triple vessel disease, I mean, in a contemporary practice, 80% of patients that we have triple vessel disease, where all the three principal coronary arteries are involved in obstructive disease. When these patients, the triple vessel disease category of patients, had a syntax score between 23 and 32, they had a class 1 indication for a CABG and a class 3 indication for a PCI, which means you should only be doing a CABG and not a PCI. And when they looked at the patients, these patients definitely had a better outcome in terms of MACE. that is, major adverse cardiac and cerebrovascular events. And they had a better and long-term survival outcome.
Yes.
Now, we are now looking at effective procedures. We are not looking at the data which has been published where there's been experience with 2 or 3 year survival outcomes. So we are looking at longer outcomes, at least 5-year outcomes.
Yes.
Yeah.
This is why, again, we're having such a program, so that we can try and explain to you these different things that need to be known and understood when a patient is confronted with the chance that he may have to have some kind of coronary artery disease treatment. And the next question that has been sent to us by one of our viewers, Dr. Ghandhiraj, is: what are the current trends or approaches in doing a heart bypass operation or procedure?
Well, the conventional approach is doing a coronary artery bypass operation using the heart and lung machine, that you attach the patient to a heart and lung and achieve cardiopulmonary bypass, and you stop the heart and you do the heart operation when you do the anastomosis and do the actual coronary bypass operation. That has been the practice over the years. But since the early 90s, there has been a trend towards doing a coronary artery bypass surgery on a beating heart, which means you are not using the heart and lung machine, and that is known as the off-pump technique. Using the heart and lung machine and applying cardiopulmonary bypass to patients does carry some risks to the kidneys, where there could be a potential renal impairment, there could be a potential risk of cerebrovascular accidents occurring, and other non-physiological conditions which may occur during cardiopulmonary bypass. So there was a huge switch when some of the results of off-pump were published in the early and the late 90s, where surgeons stopped doing a coronary artery bypass surgery using the heart and lung machine and switched because they felt the results were better and the eliminating the potential risks of cardiopulmonary bypass surgery. But then the current results, the current publications, experience tell us there's really no advantage. And when you look at the risks of potential risks of poor renal outcomes, poor cerebrovascular outcomes, they're more or less the same. So what we see now is 80% of the surgeons throughout the world still do coronary artery bypass surgery on the pump, that is using the heart-lung machine. And about 15 to 20% of surgeons still do bypass surgery on a beating heart. But one must remember that most of the heart operations are still being done using the heart and lung machine. And coronary artery bypass surgery is a palliative operation. Once you do a bypass operation, it does not protect you and does not give you a lifelong survival outcome. You do come back for recurrent disease, or your grafts could block off, or your native coronaries can become increasingly diseased. So hence, when you do the bypass operation at the first instance, you have to do it 100%, but the greatest perfection that you can achieve, so that there's long-term outcomes and there's potentially greater graft patency in future.
Yeah. Well, quite naturally, it leads on to our next question. What is your recommended approach for heart bypass operation?
I would do, and I'm a strong advocate of doing the heart coronary artery bypass surgery using the heart and lung machine. That is the on-pump technique, where you hook the patient up to the heart and lung machine and arrest the heart and do a proper job, proper coronary artery bypass anastomosis. Because of the increasing tendency for cardiologists to use PCI, the type of patients that we actually see have a tremendous amount of comorbid factors. They have been intervened previously. You're beginning to see diffuse coronary artery disease previously intervened by cardiologists. And you're also seeing, particularly in Asia, smaller coronary vessels. So I do my operations using the heart and lung machine.
Okay.
I still use the LITA, or the left internal mammary artery to the left anterior descending artery, and saphenous vein grafts. And if necessary and if it's possible, I attempt to do a total arterial coronary artery bypass surgery, which seems to have evidence of better long-term survival.
It's very interesting, and I think you touched just now on the fact that there is off-pump surgery and off-pump bypass surgery being done. The other question that we were going to ask is, are there any other approaches available for heart bypass operation? And obviously the off-pump is one, but is there anything else that you would perhaps help us understand?
Yes. There are minimally invasive techniques. One such technique is called mid-cap. Mid-cap meaning it's direct coronary artery, minimally invasive direct coronary artery bypass grafting, and it's done through a small lateral thoracotomy incision, and it's mainly being used for the LITA to be anastomosed to the left anterior descending artery. Such an incision is not recommended for multi-vessel grafting. And then we have robotic assist coronary artery bypass grafting. Sometimes it's known as a totally endoscopic coronary artery bypass grafting, otherwise known as TCAP. Now the experience is limited, and it's not a technique which is very reproducible. You can't teach your younger registrars and junior surgeons, and it has been done in some centers. But again, we do not have the appropriate literature evidence to show that is the way that we ought to do bypass surgery. What is currently being looked at and what is being practiced at the moment is also what is known as hybrid coronary artery bypass surgery, where you have an LAD lesion. You can do a mid-cap, do a LITA to the LAD, anastomosis, and then subsequently treat the other lesions using your cardiology colleagues, where they can do a PCI. And that is a hybrid solution for patients.
Yes.
And again, attempting a minimally minimally invasive approach for the patient here.
Well, Dr. Ghandhiraj, is actually it's a complicated area, and I think it's no wonder that many people are left with many questions. But I think the most important is that patients or patients' families must ask those questions. They must be clear in their own minds what is wrong and what needs to be done. Lifestyle seems to come up in almost all of our interviews. Is there a lifestyle change that you would like to recommend that people should be very much aware of to try and avoid themselves having to come and talk to you about a bypass operation?
Well, definitely. I mean, we all know, and I think it has been, spoken at length in the media everywhere, that coronary artery disease is a preventable disease. Of course, we do know there is a genetic component which we are still investigating, but by and large, a sedentary lifestyle, obesity, hypertension, high cholesterolemia, all those smoking, all these they are real risk factors for someone to develop coronary artery disease. And if you look into it, have a good dietary habit, exercise, I'm sure one can prevent coronary artery disease. And if you do have those high risk factors, family history, you can take measures to see your doctors early enough to find out if there's something that you may have that you can be treated, like, for example, if you have diabetes or hypertension, or if you have been smoking, to stop smoking. Yeah.
Maybe the last question I should ask you is, if those patients you've operated on,
Yes.
have they changed their lifestyle after their operation, or do they go back to the habits they had before they were operated on?
Well, that's a very good question. Well, 90% of my patients, and this is my personal experience, they have changed. The patients who have been habitually smoking a packet of cigarettes have just stopped smoking. And of course, there are about 10% of patients who didn't change. I mean, they changed for a while, for 6 months to a year. And when they got really better, they went back to their old habits, smoking and not looking after their diet, and so on and so forth.
Yeah. Well, that doesn't sound so good, does it?
Yes.
I hope you've enjoyed this interview today with Dato Dr. Ghandhiraj Somasundram. We thank you very much indeed for your time. I touched at the end on lifestyle, because lifestyle is an important factor in ensuring that we do the best to keep ourselves healthy. But just as Dr. Ghandhiraj has mentioned, unfortunately, even though some patients go through bypass, they tend to slip back to those lifestyle habits, which perhaps got them there in the first place. With that, we hope you've enjoyed this edition of Straight Talk today. Please do visit us at Medical Opinion Asia on our web portal, www.medicalopinionasia.com. Thank you.